Good morning. My name is Sridevi, Rajeeve. I am a multiple myeloma and cell therapy specialist at Memorial Sloan Kettering Cancer Center in New York. Thank you for the invitation, Jenny, and the HealthTree team. It's wonderful to be here. It's so much warmer down here than in New York right now. So, I dressed for New York and came, and now I'm regretting it. But it's wonderful to be here. So I'm going to come down here because, this is a breakout session. This is supposed to be free form, and, we can just talk about newly diagnosed myeloma, MRD testing, and the like. Absolutely. Yeah, absolutely. So one of the discussion points that HealthTree wanted me to discuss today was MRD testing or measurable residual disease testing. So there's lots to talk about it. We can talk on for days and days. But before I start on that, I wanted to get a pulse of the room. How many of you have heard of MRD testing? I'm going to say 75%. I do see some hands that are not raised. So for those people for whom MRD and MRD testing is a little bit of a new concept, I thought I'll go into some basics of what exactly constitutes MRD testing. How do we test it? Why do we test it? What are the latest advances? And where is the field going on towards? So MRD, this is a term that you will hear in the course of the diagnosis of myeloma, as well as all your treatment paradigms moving forward. It used to be called minimal residual disease, but the more modern term is measurable residual disease. And what that actually means is that once a certain phase of treatment has ended, and the goal of treatment is always remission, to get the cancer to the least amount possible. But despite our best treatments, when or if there is a little bit of residual disease remaining, that is what is called as measurable residual disease. And now that definition tends to change depending on the strongest or the most sensitive test that we have. Because you can imagine, when we test with blood and you look at your serum protein electrophoresis or your immunofixation testing and your M spike is 0, yay, that's great. And then you see that your immunofixation is not showing any monoclonal protein, excellent. So that level of testing, we are testing for the presence of myeloma in 1 in 10,000 cells. Okay, so that's at as far as depth down we can go, 10 to the power of minus 4. We have newer techniques, not really in the peripheral blood, but in the bone marrow sample. And all of you probably have done bone marrow biopsies ad nauseum in this journey. A portion of the bone marrow aspirate is sent for what is called as flow cytometry. Now, flow cytometry, this blood is run through some special machine, and that machine is able to sort out these cells into a single file. And there are lasers, or there are mechanisms of reading how much surface proteins are there on top of these cells, and then we have estimates. That is what is called as flow cytometry. The depth to which flow cytometry can detect myeloma cells is 10 to the power of minus 5. Like 1 in 100,000 cells. So as you can imagine, when your results come and your blood results are showing, great, your M spike is 0 and your immunofixation 0, but the flow cytometry is saying abnormal cells detected, that means you still do have measurable residual disease detected by the flow cytometry, which is a more sensitive test than your M spike and your immunofixation. So that is 10 to the power of minus 5. Now, in the last few years, we have been able to have a more sensitive test. We are always greedy. We want better for our patients. So we thought, what if we take, okay, so your flow cytometry is also negative. Excellent. So your bone marrow is clean, your peripheral blood is clean. But is it really clean? So we wanted to see, instead of looking at 1 in 100,000 cells, can we design a test in which we are looking at 1 in a million cells? That is 10 to the power of minus 6. And that is using a special technique called next generation sequencing. Many of you may or may not have had that test. It's called, adaptive or clonoSEQ, if your provider has mentioned to you about it. That is, at this time, one of the most sensitive tests that is FDA approved that we can get our patients tested for, and that is 10 to the power of minus 6. And if you're negative at 10 to the power of minus 6, that's excellent. And it's at that point in which we say that's MRD negative complete response. And then we now tend to specify, is it 10 to the power of minus 6 or 10 to the power of minus 5? So that is a background of what exactly does that measurable residual disease mean? How are we testing? So we have blood, we have bone marrow testing, and within the bone marrow, you can send it for flow cytometry, which is standard, Almost all laboratories are able to do flow cytometry, and then a lot of specialized centers also are able to send it for next generation sequencing to Adaptive to do this test called clonoSEQ. Has any of you had clonoSEQ over here? Great, I see a few hands, great. So you know kind of what I'm talking about. Although it's not quite easy to interpret those results, but again, a negative is a negative, which is great. So that's a background about what exactly does MRD mean, how do we test it? Why do we harp on so much about MRD? This was not a point of discussion 2 to 3 years ago. So MRD is a concept that we borrowed from leukemia. In leukemia, very deadly hematological or blood cancer counterpart that we have, because of that nature of the disease, the leukemia specialist especially really wanted to go as deep as possible to see if there's even one leukemia cell present in children or adults. So similarly, we started developing those tests for lymphoma and for myeloma, and we started adapting and going down as deep as possible. The gold standard for whichever treatment that we try to have for myeloma is something called as overall survival. Has anyone heard of overall survival? Probably, yes. That used to be and continues to be our gold standard in all of our clinical trials. The ultimate goal is to see, can this drug or a combination of drugs help you have an overall survival benefit over standard of care? Now, to demonstrate overall survival, you can imagine if there's 100 or 300 patients in a trial, you kind of have to follow them to the end of their lifetime, which is great, but that's probably 25, 30, 40 years later. So you can imagine a clinical trial, the results of the clinical trial can only be interpreted decades down the line. So to really understand the benefit and to really bring drugs earlier to the market, we cannot always rely on overall survival, especially in a disease like myeloma, where fortunately patients are living on for decades. Now, overall survival continues to be a standard in oncology because, unlike myeloma, there are many other cancers in which patients unfortunately do not live that long. So in 5 years or 10 years, we are able to get overall survival. I'm talking about pancreatic cancer, gastric cancer, certain types of lung cancer. That's not the case with myeloma. Patients live on for decades. We keep following them, but to really see if this drug is giving us benefit, we cannot wait 25, 30 years down the line. Therefore, we try to see what is the next best thing other than overall survival, and then we ended upon the best surrogate, and which is called progression-free survival, or PFS. So a lot of industry standards when a drug comes to market is really looking at, does this drug or a combination of drug have a benefit over the standard of care with which it's being studied for progression-free survival? Now remember, any clinical trial that you do for myeloma or any other cancer, there will not be a placebo. It's unethical. There never has been and there never will be a placebo as a control arm. It's only if observation is the standard of care will the other arm be observation. There will never be a placebo trial. So therefore, progression-free survival became a gold standard which many pharmaceutical companies and academic institutions tried to demonstrate to bring a trial or to bring a drug or a combination of drug to the market. Again, all these drugs that are now coming to the market, right, we have to demonstrate PFS benefit. Those are all the lovely curves that all my colleagues showed you. The higher up the curve, just to interpret all those curves for you, the higher up, the flatter it is, the better it is. The more lower it is, the worse it is. So you always want the curve to be higher, and that is a marker that this may be a drug that has a progression-free survival. Again, when these drugs are giving you a progression-free advantage, meaning you're on the drug, the disease doesn't come back for 3 years, 5 years, 7 years. Again, we are waiting an average of 7 years or 10 years maybe, on an average, to really see the efficacy of that drug. Do we have the time to wait? We probably do. That's how we got things done. But is there a better way to get things done other than just waiting for overall survival decades later or progression-free survival 5 to 10 years later? And therefore, we try to see, again, what is the next best milestone we can target that can be used as an endpoint in clinical trials to really try to bring drugs to the market. And that's where minimal residual disease or measurable residual disease came to the front. We did a lot of studies in which we showed that anyone who has a demonstrable negativity, either at 10 to the power of minus 5 using flow cytometry, or even better, 10 to the power of minus 6 using next generation sequencing, And when we compared those who were MRD negative and how they had their progression-free and overall survival, it was very consistently those who were MRD negative. Remember on the curve, the topmost curve, they had a direct correlation to having live longer, live progression-free, and really have better benefits. And therefore, there were a series of clinical trials that looked into it. There were some meta-analyses that were done by many different groups, the University of Miami being one, and there were other groups that really looked at over 20 different clinical trials, over 12,000 patients, and they collated all this information together and really found that all these patients who are MRD negative, they had a consistently better progression-free survival and overall survival. So what did we do with that information? Exactly 1 year ago, April 12, 2024, all this data was presented to the FDA, and there was a big meeting with the FDA and myeloma specialists. It's called as ODAC, ODAC, Oncology Drug Advisory Committee. All this data was presented, and the FDA, for the first time in its history, unanimously, 12-0, voted to have MRD as an endpoint in clinical trials, which is excellent because MRD can be tested as early as 6 months or 12 months. So you don't have to wait for 3 to 5 to 7 years for a progression-free survival to demonstrate that, hey, this trial is positive, we can now bring this drug to the market. No. At the 1 year time point, you can get an early signal as to whether this drug or a combination of drug is going to be effective and really take it forward. So that was a big, big achievement. Myeloma led the way. None of the other blood cancers have had that privilege of having MRD as an endpoint. Myeloma led the way. The FDA heard us. They approved it. So a lot of the modern trials in myeloma now has MRD as an endpoint, especially if the drug company and investigators feel that this is a new and active drug. We always incorporate MRD as an endpoint so that we have an early idea rather than not waiting for years and years to see if this drug is going to be effective. So that was a big, big change that came forward. Now the big question, what do we do with this, right? Do we have enough data to really guide treatment decisions with our MRD negativity and positivity? I think we are 25% there, 75% is unknown. All these trials, some of them Dr. Hansen talked about, the Auriga trial that's really looking at daratumumab and the addition of daratumumab to a standard lenalidomide maintenance. Does it deepen your MRD response? And even if it deepens, what can we do about it? There are other trials. The MASTER trial looked at a combination of DARA-KRD patients, and those who achieved MRD negativity, the trial was very ambitious. They just stopped treatment altogether. And then they looked at how did patients do over the course of the years. And what they found was people who are MRD negative tended to do really well. And in those patients who are MRD negative, there was a big disease biology that altered the course of how patients did, and that is whether or not they had high-risk cytogenetic abnormalities. So getting to MRD negativity, excellent, but that's not the end game. The disease biology plays a huge role, and that is kind of out of our hands, but gives us an idea that this is something we should keep an eye on, and that just because you achieved MRD negativity, we don't sit tight, we don't sit pretty, we keep a close eye on whether the MRD negativity is sustained, to really see whether we can stop treatment. So what are the potential applications? Number one, I talked about it, which is the fact that we can really now bring drugs earlier to the market than the past decades combined. With all these new clinical trials having MRD as an endpoint, there's hopefully a faster turnaround of new molecules entering the market, us being able to do new clinical trials, combinations, investigator-initiated trials, and really having more and more options come. So new clinical trials. The second, and I think the question that will be answered first in terms of treatment decisions will be, can we de-escalate therapy? We have the Auriga trial for that. There are some other maintenance discontinuation trials, including an IIT that is being done at MSK, that are looking at exactly the same question. For example, if someone is on maintenance, let it be lenalidomide or a combination of lenalidomide with daratumumab or a proteasome inhibitor, if someone is consistently negative for 2 or 3 or 5 years, do we have enough data to stop treatment and stop treatment reliably? And that is a big question because these are not benign drugs. We know, in our clinic when we see patients, we have patients coming and talking about Revlimid diarrhea, neuropathy, really not tolerating treatment, but they still go on with it because you have to. But do we know in a data-driven manner that this is the time point in which it's considered safe to stop treatment. We don't have the answer yet. We are very, very close to it, but that's going to be one of the really big important questions to answer. Can we de-escalate treatment based on MRD negativity? Now, the flip side, if someone is MRD negative and converts to MRD positivity, I'm sure some in the audience may have experienced that. Over the course of years, you maintain that MRD negativity. It's something called a sustained MRD negativity, and that's much more important. Rather than one time point of negativity, what is more important is the negativity being sustained. Let's say there have been consistent negative results for 2 years. The third year, unfortunately, that damn clonoSEQ is picking up residual sequences. You're now MRD positive. What do we do with that data? We don't have an answer just yet because there are strict guidelines on the International Myeloma Society of what constitutes progression. Just because clonoSEQ turned positive or just because flow cytometry turned positive, but if you have all other markers negative, your imaging's negative, the rest of the bone marrow is negative, that does not constitute progression. So do we really need to put you back on treatment or escalate your treatment or give you more toxic treatment? We don't know. We are doing studies to understand that, but that is a question that will be answered in the next few years. And that's important because the moment you see that MRD positivity in someone who was previously MRD negative, very anxiety provoking. All that, complacency we had for all these years washed away. The other question, somebody's in remission, never became MRD negative, but has been consistently MRD positive at a very, very low level. Do you treat? Or do you let it go, right? There are new data suggesting that for patients who achieve a remission and who probably do not go into a full deep remission, their myeloma may change, and this is a very small subset of patients. The nature of the myeloma may change into something resembling an MGUS, meaning you can detect it, but it never ever transforms. It just stays there below at the level of detection, never really progresses onto myeloma, never really harms any of the organs, and never really progresses. So if someone's detectable disease is behaving like an MGUS, again, do we need to slam it with chemotherapy? Probably not. So that's like an over-information. Having all this MRD data to escalate treatment, that would be something that I would be very, very worried about and really not try to do it until we have data to really see, should we escalate? I'm more excited about how can we de-escalate. That should be the first question to answer. Like patients who are on treatment for 7 years, 10 years, can we now de-escalate treatment? Rather than just because someone turned positive, should we escalate treatment? So these are some of the clinical questions about MRD that are now being answered. And the other aspect about MRD is that the FDA really gave us a guideline of how should MRD be tested. It should either be flow cytometry that has the power for 10 to the power of -5, or next generation sequencing 10 to the power of -6. It should be done at least at 9 months or 12 months post. And there are newer definitions that are now coming for sustained MRD negativity. You should have at least negativity for 2 years before we can call it a sustained MRD negativity. Later this year, or probably early next year, there's a group of our colleagues that are working on a possible definition for cure for myeloma. That's very ambitious, but we are doing it because all of us have a subset of patients who meet that criteria. And I'm not going to give away what that criteria means, but I can tell you that MRD is a big part of it. And we want to demonstrate sustained MRD negativity over a period of many, many years. And if all criteria are met, we are hoping to change the definition of myeloma as an incurable disease and to maybe a subset can be cured. So MRD, very, very strong tool to really guide treatment decisions. Not yet, but hopefully soon. But this is something that you should talk with your doctor and what it means and really not try to interpret all on it yourself and be anxious all the time. So that's an overview. I'm happy to talk about it more or take questions right now.
I have a question.
Yeah.
I'm going to bring a mic. Yeah, I'll bring a mic around. Ashlyn, can you make sure this one's turned on?
Thank you, ma'am. I'm just not clear because I think I mentioned to you both that my MRD is 1 in a million.
Yes.
and I'm going for my BMT oncologist handing me back to my primary oncologist.
Yeah.
So can you explain or clarify the transition to PFS or achieving MRD negativity? I mean, I think I would be on Revlimid 10 milligram plus Velcade.
Yes.
Are these two enough or?
So from my understanding, from what you just said, it sounds to me like you've been through your induction treatment, got through transplant, and the post-transplant assessment, probably at 3 months, there's MRD positivity. But the bone marrow, and that was a bone marrow sample, do you know the flow cytometry?
It's all here, but we don't know how to read it.
That's okay. That's okay.
And I don't know if, okay, we were just told on the last visit about the clonoSEQ,
clonoSEQ, yes.
and I want to tell you, I learn a lot from, I don't know if it's Dr. Google, but is AI the same as Dr. Google?
That's Dr. Google's newer, fancier cousin, yes.
But it's helped me.
It's helped, yes.
And
Yeah.
I do know I have to run, okay, but anyway, we do have the stuff here, and I don't know, we never saw it said clonoSEQ, but I believe this is it. And I wanted to ask if NSG is the same as,
It's probably NGS, and it's the same as clonoSEQ, correct.
so that's, okay,
It's all different names.
because the next generation sequencing, I didn't think they did. But if they did clonoSEQ, then they did next generation sequencing.
Correct. So
But the doctor, when I addressed it to her, she couldn't even find the clonoSEQ. And she said, oh, I don't think it's back yet, but yet we have all of our bone marrow study here.
Yep.
And then in her report, she was gonna get back to us about the clonoSEQ, but in her note, it said, 1 in a million. So we're like, where do I see the clonoSEQ written?
right. I think, it requires a little bit more of a deep dive into your records, but 1 in a million, the chance of that report of it being clonoSEQ is like nearly 100%. There's mostly no other test unless your institution has flow cytometry that has 10 to the power of -6. Most institutions only has 10 to the power of -5, but some institutions have the power to do 10 to the power of -6.
So this says 10 to the power of -6.
Okay.
And we can look at it too.
Yeah, we can look at it. But in general, right? In general, it sounds to me that you had a very good response. And 1 in a million cells is considered, yes, MRD positive. But I'm assuming, again, not looking at your medical records, that the rest of your labs and your imaging are indicating a complete response. Probably.
He's the 414, 2414.
414. Again, a big reason why Velcade was added to your maintenance regimen.
But then we heard today about 4 chemos, or why?
I forwarded our forms.
So I guess we don't want to take up all the time.
No, great. So, like I said, MRD is not yet ready for prime time. MRD is not enough to make a lot of these treatment decisions standard. If you've had a good response, anything which is a VGPR or better, you are eligible to go into maintenance treatments. Okay, the standard maintenance used to be lenalidomide. If there are some mutations in which we think confers a high risk, or some mutations in which we think that there could be a benefit by adding a second drug, in your case with the 414, with the Velcade, we add that. There is a chance that this MRD positivity down the next few months can turn into an MRD negativity. We have seen that in patients. So it's not like this MRD positivity is like a one and done deal. The myeloma can still evolve and become negative over the course of time.
So my follow-up question is that negativity, would that indicate PFS?
Yes, like I said, we've done a lot of studies in which we have shown the correlation of MRD negativity directly correlating to an increased progression-free survival and therefore to an overall survival. Yes. So this is appropriate, what you're getting.
And how do you know if your doctor is a multiple myeloma specialist? And they're not just oncologists, but
Great. The question is, how do you know if your doctor is a multiple myeloma specialist and not? So all physicians who treat multiple myeloma have to go through different levels of training, specialization, super specialization, and then we choose to land on one disease, right? A lot of us who work in academic centers, we have the privilege to do so because the institution is able to hire a lot of physicians who are able to focus on different diseases. If your physician treats only myeloma, they're a myeloma specialist. In a lot of practices, they might focus on myeloma and lymphoma. Still, they're focusing on two diseases. In community practices, there may not be enough physicians to cover every single disease, so they may need to focus on all blood cancers or blood cancers plus breast, etc. That's how you know.
Okay, thank you.
Yes.
Just in general, so it's an interesting study to determine this endpoint of treatment.
Correct.
So we haven't had that study yet. So in your practice, when you get somebody who has a low FISH,
Yeah.
low risk, and they've been on standard post-transplant therapy, and
Yeah.
they've done well for 5 years, and
Yeah.
they're MRD negative, even at the new test, the
Yeah.
1 in a million.
Clonoseq, yeah.
What do you use to decide? How do you look at that patient? Different ages, and no physical toxicity to treatment in anything. So
Right.
they're doing well. This is your ideal patient. Then you look at them, and in some of the studies, there's a German study and some things where in everything, even lenalidomide studies where they show longer survival, longer disease-free, staying on treatment. So to take somebody off all treatment seems like a daunting decision. How do you do that?
It's very nuanced.
In your practice, because we
Absolutely.
don't have the ultimate answer.
Correct. We don't have the data just yet. So at MSK, we try to do it in a combination of ways. One, everyone gets MRD at their restaging. Like at the yearly restaging, everyone gets MRD, everyone gets Clonoseq, and so we can track sequentially over time how are patients doing. The second thing, once you treat a patient over the course of years, you kind of have an idea of how fast generally has the myeloma relapsed. We know for some patients, you see an uptick of an M spike or an uptick of a free light chain, and then even if 7 months later, that uptick may be slow, but in some patients it might be fast. So the kinetics of the disease, the age of the patient, if this is someone who is very young, 40s and 50s, it might be in their good interest to remain on them. If it's someone in their 60s, 70s, 80s, and who has already done a decade and do want to get off it, we do have an honest discussion. This is where the data lies. We also have a trial at MSK which directly looks at patients who have had 5 years of MRD negativity, Clonoseq MRD negativity, and they can go into a discontinuation. We follow them exactly the same way, but they go off maintenance. And that data was presented at ASH by my colleague, Dr. Corday. 89% patients remained MRD negative at 2 years post-discontinuation. That's a very, very high number. That's almost 90% of patients who remain negative 2 years after stopping treatment. But these were patients who for 5 years never had any, and they were consistently MRD negative. They were not patients who were MRD positive and negative. There was also the subset of patients who, like I said, they did well, but then some converted, you stopped maintenance, some converted, but then never progressed. And their myeloma behaves like an MGUS. So we never really started them on treatment. So essentially, it was close to 94% of patients who we never really started any treatment on because they never relapsed, right?
How far out do you have data?
We have data of at least 4.5 years now. 4.5 years out, because the last patient who went into the trial was somewhere in 2022. So once that patient hits the 5-year follow-up, we'll have a little bit more of a robust data. There's also one aspect I wanted to bring about. Every time I have a discussion with a patient about stopping treatment, I have to say 70% of the time, they don't want to stop treatment. Very, very on the fence about it. I have patients who are 7, 10 years on treatment. They're like, please, this has been working for me. I have 0 side effects. I want to go on for a few decades more. I do not want to stop treatment. In fact, the people clamoring to stop are very less, at least in most of our practices, because everyone's like, why shake the boat? This is working for me. And especially these are patients for whom there are no side effects, like you said. Compliance is also a big thing. Like if I know this is a patient who can be expected to follow up in clinic, I would be much more comfortable. There are patients, especially in the New York metropolitan area where we are coming from, a lot of underserved population who reliably may not make it to clinic each time. Like, we ask them to come every 3 months. I'm lucky if I see them once a year. Still, I keep renewing their Revlimid, but they still come in. They still do miraculously well. But those would be patients I'm a little bit hesitant to stop because I'm like, once I stop, will they ever come back? So it's a combination of decision making. Yes.
Okay, just 1 second.
So the original presentation that we saw made it pretty clear that having the original presentation that we saw made it pretty clear that the 4-drug combination was clearly superior to the 3-drug.
Yes.
But imagine for a moment that you're having a really bad reaction to one of those 4. Do you tough it out and just say, okay, I recognize that I'm going to have these negative reactions, these side effects that are going to be really bad, and I'm going to just accept that because the benefit is so much greater? Or do you accept the notion that you're just going to go down to a 3-drug, regimen?
So to really answer that, there needs to be a little bit more of a discussion into where did they start from? What was their starting point? Not every patient's starting point is the same. Some might come with an M spike of 2.5. Some might be coming with an M spike of 8. The goal is always to get them as close to 0 as possible. If it is someone who is the latter, high disease burden, we try to dose reduce the drug instead of completely omitting it, because we do know that the MRD negativity rates, the complete response rate, and the overall response rates of the 4 drugs is much, much better than the 3 drugs. That's not to say you saw the results of the Maya trial, the DARA-RevDex trial. Extremely good results with 3 drugs alone. Often, the first drug that we peel off, in addition to lowering the dexamethasone dose, is the Velcade because of the neuropathy. So even if you dose reduce the Velcade and eventually take it off, you may still have the benefit that the Maya trial is showing. So you may have the benefit somewhere between the Maya trial and the Griffin and Cepheus and the Perseus trials. So anywhere between 50 to 80, you will still have a percentage of response. So I always try personally to see what is the grade of intolerability. Are they having a grade 1 or a grade 2 adverse effect? If it's grade 1 and grade 2 and there is specific grading, I try to lower the frequency of the drug or reduce the dose of the drug. If it's grade 3 or grade 4, meaning completely intolerable, there's no other way, you just take that drug off. Yeah.
Or can you even swap it out with a drug in the same drug class?
We
so
can.
Like, if you have a reaction to DARA, could you use isatuximab or something like that?
I've rarely replaced DARA with ISA because DARA usually gets very well tolerated. I mean, for the patients for whom I use isatuximab, typically tends to be the, at least based on the FDA approval, the transplant ineligible patients for whom ISA VRD is approved, under the age 80 and those who are eligible. And they also do well. But the drug that's often swapped out is Velcade and carfilzomib.
Yeah.
So Velcade because of
Neuropathy
and then carfilzomib is usually well tolerated as long as they don't have a major cardiac history and their echocardiogram is normal. You can do a swap class. Revlimid, there have been occasions in which we have tried getting Pomalyst, but again, very hard to get approved in the newly diagnosed setting. Insurance always gives us pushback. Why are you starting them on Pomalyst? Because you can't show disease progression. Mm-hmm. But for intolerance, again, there's a big insurance approval also, but it's easier to get the swap of Velcade and carfilzomib and DARA and ISA rather than Revlimid and Pomalyst.
Mm-hmm. Okay.
So it is the Darzalex that's the problem for me. But it's, the question is, what is a level, what's a level 2, what's a level 3, problem? In my case, it's been incredible rashes surrounding, something in the order of 4 to 8 inches of rash space around the injection. And that caused my oncologist to say, let's pause this for 2 months.
Yeah.
And in the same time, Velcade was introduced, and all of a sudden, my numbers are going in the right direction.
Yeah.
Where it wasn't with just...
So your initial was daratumumab.
And Revlimid and Dex. That was
So
it.
Dara Revdex, and it was switched to Velcade Revdex. Okay, yeah.
And now all of a sudden the numbers are getting great and the Darzalex is out of the picture. But but looking at those results, I say to myself, is that a problem?
No,
long term?
I mean, for the sensitivity and the reaction to daratumumab, you're not alone. We have a lot of patients who do that. There are some patients who respond well to isatuximab, as Jenny was saying. The isatuximab binds to a somewhat of a different surface of the CD38 antigen, so that can be trialed. The other, which again, if your team has a good dermatologist, there has been probably not my patient, but one of my colleagues' patient, in which we try to desensitize them to daratumumab. The dermatologist can do that, a desensitization. It's a stepwise way. But that's probably if Dara is like your only go-to drug. That's not in your case. You can try isatuximab. I will say, though, that if you're having a very good response to triplets used to be the standard of care for many, many years. It's since probably 2018. Dara was introduced in 2015, 2016. A lot of these quadruplet trials came to being in the last 7 years, and all their results are being reported in the last 2 to 3 years. The Griffin trial, the Cepheus trial, the Perseus trial, all of them. So the world is moving towards, I'm not going to make any excuses for it, the world is moving towards quadruplet eligible versus non-eligible, right? And quadruplet non-eligible is your frail patients, traditionally considered transplant ineligible. They tend to be, in which we know that 4 drugs will be too much for the body. However, 3 drugs is it continues to be an appropriate treatment regimen. And if VRD is doing that for you and it gets you to a complete response and hopefully MRD negativity, there you go. And in future, if you do need a CD38 antibody, you can try either isatuximab or a desensitization to daratumumab.
Yeah, I know you talked about patients who, when they're to MRD negative for 5 years, and they're hesitant to stop treatment.
Yes.
So what if you've been on, myself, Revlimid for 5 years now, 10 milligram, do you see any benefit in those patients just reducing to 5 milligrams of Revlimid?
Yes, again, like I said, it's a shared decision-making with the patient. When we talk about discontinuation, we don't have that data just yet, right? The trials that we are doing, the studies that we are doing is still maturing. We don't have that data just yet. If you have done very well and you're MRD negative, I think it's a discussion you can have with your oncologist to reduce you to 5 milligrams. The patients for whom I reduce to 5 milligrams are usually those for intolerability, rather than, okay, they reach 5 years and now I can reduce to 5.
So there is a reason, like toxicity or something that...
I try to go with where the data shows, because how do I justify my decision-making to an external person or an insurance or an auditor, right? Or, anyone who sees my patient. Why did I do it? If the patient wanted it, sure, I document it. And that's not unreasonable. I have inherited patients from colleagues who left the institution who have been on 5 and who have done very well on 5 because that's the minimum biologic dose they need to keep their myeloma in check. It might work for you. I've definitely had patients like that who I've inherited, but me, myself, when I've lowered, it's always been for intolerability. But it's not unreasonable. Definitely have that discussion.
Okay, other questions?
I myself have been smoldering for 5 years,
Yeah.
and then I went 4 years without a bone marrow biopsy, and I just had one done 2 months ago. So my bone marrow biopsy went from 30 to 40 to now 60 to 70. And my last 4 visits in the last year have shown my numbers going up every 3 months.
Yeah.
For the last 4 years, it used to take a year and a half to get to that.
Correct.
Now I'm doing that in a 3-month period. So my question is, I trust my doctor and everything, right? But you hear some people, like right now I'm going to get the induction done to do my transplant. But you hear some people say that they might just do a harvest and get their stem cells harvested frozen, but not go on with the transplant. They rather just possibly go with chemo medication. But by what one of the oncologists showed the slides earlier with the transplant, you just have a better overall outcome. So I'm sure you agree with that. And if so, have you seen any people not doing the transplant that are fully blown myeloma and have good results? You hear different things, and the majority is the transplant, of course.
Correct.
But I just want like your experience on what you've seen on that.
Absolutely. So when I initially heard, I was thinking, is there a confusion between the fact that whether you have myeloma or not, but there's no confusion. We now know the disease has transformed. It is myeloma. You're going through induction treatment. The question is, do you collect and go directly to transplant, or do you collect and store and keep going with chemo, and can you do transplant later, correct? Yes, okay. So again, we have done a lot of studies in which we try to dethrone the role of transplant in multiple myeloma. Trust me, none of us want our patients to go through it. Everyone comes back after that. Not everyone. Some people tolerate it okay, but most people don't. And they come back after 3 months and they don't tolerate it as well. But, with the latest data from MRD data, this is how the numbers stand, okay? So at the end of induction treatment, with a quadruplet therapy, you can get an MRD negativity rate somewhere around 35 to 40%. The addition of transplant gives you an extra 20 to 25% of MRD negativity. And when you go on to maintenance with lenalidomide, and when you sustain it, your chances of being MRD negative is 65%. As opposed to a pathway that doesn't have transplant, which is 3 or 4 drugs, no transplant, and then directly go into maintenance, your chance of getting MRD negativity is in the 40s. So there's a clear 20% difference in what previously used to be called the progression-free survival advantage of transplant is also being seen in MRD negativity rates. That's number one. The second question is, what about transplant now versus later? That also has been extensively studied, and there have been, I can show you graphs and I can cite all the studies, but just to make it very simple, we looked at patients who had upfront, meaning induction transplant maintenance, or went through treatment and had transplant at the second or the third relapse or transplant later. Long story short, those who had transplant upfront did much better than those who had transplant later. So because of those data, we always try to have a discussion. This is what it's showing. And for those patients, for social reasons, they have their son's wedding coming up, or I have patients who are working and they just want to hit 65 before they stop working and want to defer transplant. So many reasons why transplant is not done in the upfront setting. They have done well, but one thing I always do for them is to collect and store their cells. At the right time, maybe 4 or 5 cycles in, collect and store, and maybe for social reasons or personal reasons, they don't want to do a transplant. Sure, I can't force them to, I can show them the data, but then I also explain that your best chance is in the first upfront setting. And if you do go later, you will still have a benefit, but the margin of benefit is not that great.
Oh, not really a question, but sort of tying into what the young man said there. My journey is kind of, early, and it started with smoldering. I think I heard one doctor last month says, we got to stop saying smoldering. It's myeloma, But I looked for research. Nobody had to convince me. Notwithstanding Tuskegee and all of that, history. And the research I did was with the 4 drugs. So half of which I can't pronounce, but Dexa, CARS, and DARS, and
you have it right, 100%.
But the good news for me as a patient, as I looked at others in the room, a lot of people are sick, and they didn't tolerate a lot of those medicines very well. I had the flip side. I tolerated them very well, had immediate response. My biggest problem was, all the nurses encouraged me to eat, and I took them up on it. So, but it was amazing. Mm-hmm. We did harvest the stem cells.
Great.
I mean, that harvesting alone was enough for me to say, you know what, I don't want to come back to this place.
Well, since you did so well, I have a question for you.
Okay.
In how many days did you harvest?
I'm sorry?
Did you hit the, I'm just curious, because you said you did so well. Did they get the amount of cells they needed in 1 day, 2 days, 3 days, 4 days?
It was 1 day.
Oh my God, I expected it.
It was one long, painful, awkward day. It hurt coming out more than it did going in.
Yeah.
I'm sorry, it was just not good. But
Well, you're lucky you did it for 1 day. You know, I think 50% of my patients only get it done in 1 day. The rest of the 30% need 2 days, and the last 20% at least need 3 or 4 days. So what's that? It's a combination of, you know, disease burden, the biology of the body, and, you know, where they are in treatment. We ideally say that there's a nice balance point, you know, in between cycle 4 and cycle 6 in which you collect, and that's the time in which, if a patient is responding very well to treatment, the myeloma is at its lowest, but then your other cells haven't been exposed to as much chemo. So that's why it's so important that your oncologist refers you to a BMT specialist early on, and at least by cycle 2 or cycle 3, so that you're established with a BMT doctor. They can set you up right at the end of cycle 4 or cycle 5 to collect. Because if you collect at end of cycle 6 or cycle 7, you may need like 2 or 3 days to collect.
Just 1 second.
There you go.
Okay, we're going to go here, and then we'll come back to you two. Okay. You want to ask?
Yeah, just to follow up on the question, this may be like too granular, and I don't know if they have any information on this specific thing, but I am going to be a person that probably needs to have a stem cell transplant starting in September. That
Okay.
would be the earliest I can do it. However, I am one of those people that I don't want to gamble with my life. So would waiting till January be that big a deal? When you say people wait for, a longer period of times, is 3 months considered too long? Between harvest and stem cell?
No, it's not. It also depends on, what is the nature of your disease, whether the disease biology is standard versus high risk. At what point are you after induction? Have you had a partial response? Have you had a very good partial response? Or are you in complete response? And if you are in complete response, are you in MRD negative complete response?
Right.
So the deeper the remission, it's okay to wait as long as you have some kind of treatment. You're still getting upfront transplant.
Right.
From the previous discussion. You're not someone whose disease is relapsing and then you're getting a transplant. So you're still overall maintaining that advantage that transplant is offering, and just by delaying 3 months, it shouldn't be that big a problem. As long as your disease continues to respond, though, to
Right,
treatment.
there's still unanswered questions, but
Correct,
if
and the disease biology. If
but,
for some reason you have high-risk mutations or translocations or what we call high-risk cytogenetics, it would be in your best interest to move to transplant as soon as possible.
Okay, thank you.
Okay, we'll do one more question, sorry, and then we're going to have to hold the other questions, so write them down because we are into our lunch already, 10 minutes.
Well, this isn't a question. I would say I really liked your presentation. I wish you were my doctor. You did a good job. I see a specialist in Moffitt. She's excellent also. But I don't ever remember having a big discussion whether or not I got a stem cell transplant about 1.5 years ago. I'm in an online support group, and people are always commenting, do I want to get a stem cell transplant or not? With all due respect to this, the other young man at the end over here, I don't know what pain you were referring to. The apheresis, I used to go through something like that at the Florida Blood Center when I was donating platelets.
You're a champ.
I remember there was a certain, what's it called? I felt like I was shaking or
Some restless legs and shivering, yeah.
I've had a lot of people, I would just say the stem cell transplant, maybe I'd say it's not a lot of fun, but I did it with very minimal side effects and got good results. So some people that are hesitant, I would say, talk to some people that have gone through it. HealthTree has coaches. I am signed up as a coach. Talk to, there's a twinning program, there's a HealthTree coach, there's Imerman Angels.
Great. Can I send a patient to you? I just heard yesterday that she doesn't want to do a transplant and she's young, 50s. Talk to her church group.
I'm not going to tell someone
And I'm
what to
like,
do,
no,
but
HealthTree for
I
you.
would tell them about my experience and say, you know, I read so many things about all the side effects. I'm like, to me, it was pretty minimal. That's all I would say.
Thank you. That was a fabulous
Of course.
discussion.